So shall we go to the next topic?
Yes, sir.
Triage. So any idea about triage?
We have to separate the patients according to the clinical situations, like color coding, sir.
What is the meaning of triage first?
Sort it out.
Sort people out.
Sort it out.
The sort.
To
the
classify
French
the
word.
patients to get treatment accordingly.
So, is it visible?
Yes, sir.
So what is triage? Where is it used, and what are the advantages of using it? The French word which means to sort or classify or separate. The process of prioritizing patient treatment in a mass trauma. That is the main reason for doing the triage. It helps in better salvage of patients who would otherwise be dying. So sending right patient to right place, the right time for right care. This is the aim of this triage. Okay. So what are the aims of triage? To treat patients based on the urgency, to ensure treatment is timely and appropriate, segregate patients to right area to avoid congestion in the treatment area, continue assessment and reassessment to see the prognosis, provide information to attenders, and also send information to referral centers where patients are being shifted or transported from the site of trauma. So these are all the aims. And how the triage is classified? Any idea?
Red, green tag, yellow, black.
That is color
Based on the
coding,
tag.
of course. It is primary or pre-hospital, or secondary or hospital triage, and tertiary or specialty triage. So at 3 levels you can do the triage. And the primary pre-hospital triage is the most important. That only decides which patients we are going to shift and save by interventions. And once they come to the hospital, again you have to do a triage to see which are all the locations they have to be referred to and how to prepare. And once they go to the specialty, there again the triage becomes much more leaner there. So the most intense triage is done at the primary level. So pre-hospital level is based on the anatomic and physiological data, either separately or in combination. So the physiological parameters, usually we take the 3 systems into account in a major trauma. One is the respiration, the other is the cardiovascular system, third is the CNS. So respiration is assessed by respiratory rate, and cardiovascular system is by a palpable radial pulse or a capillary ripple, and CNS by BCS score. So these are the 3 basic systems which you have to assess in the pre-hospital trauma care. And what are the models used in the pre-hospital triage? Any idea about that? Okay. Earlier there were models which were called stay and treat and scoop and run. So the older method of triage, where they say stay and treat means you start the treatment at the site of injury or the trauma accident spot itself, like starting an IV line, intubating the patient, stabilizing the cervical spine injury. All these things were done leisurely at the accident spot itself. The other method is just to put the patient in a stretcher, ship them as early as possible to the hospital. So it was called stay and treat or scoop and run. But later on, it is now modified as what is called the START model, START. Can anyone tell me what is it? It's an acronym. Can you expand that?
Dono, sir.
So simple triage and rapid transport. That is the acronym for that. Do a very simple quick triage and transport the patient as fast as possible. The other one is SALT model, which is start, assess, life-saving interventions, then treatment and transport. These are the in simple triage. You don't spend much time. It is just like scoop and run. You try to identify the serious nature of the injury and as quickly as possible transport the patient. So it is equivalent to the scoop and run technique of earlier days. But SALT is like your stay and treat, where you sort, you assess whether the patient is likely to survive or not, and do some intervention and then transport the patient. Now, what is the trimodal death distribution? How it is significant in triage? Trimodal death distribution. That means how do you classify the patients who come with a major trauma in reference to their likely to survive or die? So you have three categories of trimodal means three categories. Can you just say what are the three categories? It's a logical thinking. It is nothing needed to think too much scientific about it. So, for example, you have a patient who has a fracture, hepatic rupture, who has a pneumothorax, who has a cardiac tamponade, who has multiple bone fractures, facial injury. Is he likely to survive?
No, sir.
Was already
No, sir.
examined, lot
No,
of
sir.
No,
some
sir.
pulse query, BP query. So patients who are on imminent death, that is one category. Patients who are struggling, who have some palpable pulse, who are GCS low, but still who can be salvaged. The third category is simple fractures with no major injury, who is still talking, can still obey commands. That patient is definitely not a very serious case. Okay? So this is the three categories. Death occurs due to injuries in one of the three peaks. The first peak is within seconds or minutes with severe traumatic brain injury or cardiac rupture. This patient will die within no time. So this is the first peak patient. He cannot be salvaged at all. The second peak patient is within minutes to several hours. For example, a subdural hematoma, a pneumothorax, or pelvic injuries. They all will come in shock with pulmonary, but they can be resuscitated. If you don't do it any fast intervention, they may die within minutes or hours. And the third peak is they live up to several days and then die of sepsis or multi-organ dysfunction. Okay? So this is the three modes of death that we call the trimodal distribution. So how is it significant in triage? Now having known this distribution, now you can apply your mind to see. Supposing you get these three categories of patients. And the third category is patient with multiple superficial injuries, who is not very serious, but who may develop sepsis and other things later on. And one category is already is almost at the end of his life. So which patient you will give the most important attention? First peak patient or second peak patient or third peak patient? No answer at all. Am I audible? Are you all
First.
there?
Yes, sir.
Choose one among the three. Which one you will give the first preference of treatment?
Second,
one
first
or
peak.
huh?
Second peak.
Peak two patient. This patient is less serious. He can go into complication later only. This patient is almost dying, dead. Whereas this patient, if you drain the pneumothorax or if you drain the hematoma, if you fix a pelvic fracture, he can still survive. So he should be given the maximum attention and treatment. So that is the idea of triage. Which patient to give the priority. That is the definition I told you, prioritizing the treatment to salvage the life. Okay? So triage helps in the identifying second peak patient and offer treatment to save them. And what was the earlier concept of pre-hospital? That is where I told you about stay and play or scoop and run. And how are patients sorted based on their need for treatment? They can be classified into critical. That is, within seconds you have to treat them, like airway obstruction or heart rupture. They can be immediate with tension pneumothorax or major vascular injury, or it can be urgent within the golden hour or period of polytrauma. And deferred treatment, where it is non-life threatening injuries, so you can even make them wait for several hours, no problem. So these are the 4 categories of patients you will see when you want to do the triage and treat. So how are patients classified? Based on the urgency to transport them. So this is for the treatment. To whom has to be transported? Again, it is classified into 4 groups. The expectant who are beyond help, you don't transport them immediately. That is, for example, he is almost on the verge of death. There is no point in sending him to the hospital and uh, uh, occupying a bed there, which can be utilized for saving another person who can be salvaged. The injured who can be helped by immediate transportation, the injured whose transport can be delayed, and those with minor injuries who need help less urgently. Okay? So these are the 4 categories for transportation. If he is on the verge of death, don't transport the patient. Patient who can be salvaged should be immediately transported, like patient with pneumothorax and other vascular injuries. And patients who can be delayed, for example, polytrauma with multiple fractures but stable cardiovascular system, you can wait and transport them. And patients with superficial injuries who are walking in, who are fully conscious, alert with good hemodynamic stability, they can be treated at the site of injury itself without transportation. So this is the 4 categories for transport, 4 categories for treatment. And describe the start and salt models. What is the difference between the two? And this is the simple triage and rapid was developed in 1980 as the first civil casualty. And this is the second is a SALT, which is SALT assess life-saving interventions and treatment, combined with the life-saving interventions and designed for both adults and pediatrics. So first look at the patient, whether he is able to walk. Yes means it's a very, very minor injury, given color green coding. Okay? So just make him wait and check. Don't spend time excessively on that patient. Patient not able to walk, whether he is spontaneously breathing. No, then position the airway. See whether the patient is not breathing. Is it because of airway problem, cardiac problem, or neuro problem? And whether he can be salvaged. If it is totally apneic, that means he is likely to die. So it is given as a black color coding. Patient is breathing spontaneously, then look at the respiratory rate. If it is less than 30, nothing serious. Look at the perfusion. If the radial pulse is present and capillary refill is more than 2 seconds, there is a delay. Look at the mental status and sensorium. If he is obey commands, then he goes into the yellow category where he can just wait and treat him later. On the contrary, the respiratory rate is more than 30 and capillary refill time is less than 2 seconds, radial pulse not felt, and patient's consciousness is not there. The 3 systems are affected, respiration, cardiovascular and CNS are affected. He is the one who requires treatment immediately. So that is given a red code. So red, yellow, green. These are 3 patients on the priority list. First, foremost priority is for red patient. Next priority is delayed yellow patient. Third priority is green patient. Black patient is almost dead. So don't spend unnecessary time on that. Just give some consoling thing like tender loving care, TLC. So whereas in the salt flow chart, patient is walking and the way with purposeful movement is present and still obvious life threat is there. So you have to first sort out the categories into very simple wound, moderately injured and very seriously injured. So that is the first thing is to sort out. Then after sorting out, you whether the patient is breathing or not, no breathing, no pulse, almost dead, go into black category. Breathing is there, obeys commands or makes purposeful movements, all these things you check, and all yes, that means it goes into minor categories, either at green or yellow. And only when these things are not present, then you give more importance to that and see whether he can be salvaged by immediate treatment. But if he is in the group where he is very seriously injured and going down the hill and expected to die, don't spend too much time on that also. So there is a small difference between these two. Here the category of the response to the three system is classified into minimal and delayed and immediate. And in the immediate, again you have to triage and sort out whether he is likely to survive or not by your experience and clinical response to the treatment. So the salt and start can lead to over triage or neither are sensitive or specific enough to predict clinical outcome. So after all the description, you know that this is more of a trial to do save as many patients as possible by your clinical judgment of the patient. So what is the aim of this is all in the pre-hospital or the primary triage. Once a patient has come to the hospital, in hospital triage, what you do, here the system is rapidly identify patients with life-threatening conditions and ensure treatment of clinical urgency. And there is another thing called RETTS algorithm, where it is used and what is the purpose. It is rapid emergency triage and treatment system, and it's a 5-level triage used in the emergency department of the hospital. So this RE salt and start at the primary pre-hospital triage. RETTS algorithm is at the inside hospital used in the emergency department to prioritize the patient on their severity and immediate life-threatening condition. And here the 5 categories or 5 things that you have to do is, one is inspection of the patient for airway compromise, and second is respiratory rate and saturation, third is heart rate and systolic BP, and then reactive lifespan and body temperature. These 5 things are taken into account. And again, here you classify them into red category, orange, yellow, green, and blue category. So blue category, they don't require any triage at all. Green, they are all more alert and more stable. Yellow is also not very urgent patient. Whereas red and orange are the two categories where you have to give more concern to treat. And the various categories of triage can be what is called the simple triage, which is acronym used in STAR, used in mass casualty incident to sort patients who need critical attention and immediate transport to hospital. And this step can be started before transportation becomes available in the site of accident itself. The second thing is emergency triage in lights, probably useful at night under adverse conditions. So this is another name given for triage done at the night time in a dark environment. Then there is an advanced triage where doctors and specially trained nurses may decide that some seriously injured patients should not receive advanced care because they are unlikely to survive and the medical resources available are not sufficient to treat all patients. So if you have 2 patients with similar injuries and you feel one can be salvaged and another is unlikely to survive, don't waste time on the patient who is not likely to survive. So that is the reason, especially this is done in the war settings, where especially patients who can be salvaged should be attended first and given more care. Then there is a continuous integrated triage approach in mass casualty, which both effective and sensitive psychological and disaster behavioral issues affect the number of patients seeking care. That is the patient surge and the manner in which hospital is able to accommodate them. It's called surge capacity. This is another category of surge. Then there is another condition called reverse triage, where sometimes less wounded are treated in preference to more severely wounded in a war, as soldiers with a less wound can return back to the combat, go again back to the war front and fight. Whereas a severely wounded patient will not be able to go back. So you urgently treat the less wounded and send them back to the war front. That is called the reverse triage. And under triage is underestimating the severity of illness, and over triage is overestimating the severity of illness. So these are all the various terminologies used to classify the various degrees of triage. And the color coding that is used for triage is red carries a maximum priority, yellow is the next, green, black is almost for patients who cannot be revived and will be dead any moment. So this is the category that is used. And that will end the discussion on triage. Any questions on that?
No, sir.
Doubts? Is it okay?
Yes, sir.
Yes, sir.
Put some idea about it.